Okay, hello everybody. I think we'll go ahead and get started. Welcome to the quarterly Stanford Meningioma Support Group meeting. As with the other support group meetings that we've had in the past for meningiomas, the format of this meeting will be a presentation of a topic followed by some question and answering. What I'll plan to do is if you have a question, you have the option of typing the question into the field, and I will keep a list of these questions and answer them at the end of the presentation in the order in which the questions have come in. So if you do send a question during the presentation, don't worry, I will get to it. I will just do it at the end of the presentation. So the topic that I wanted to talk about today is a topic that I did talk about in the past about 5 years ago, but because it's been a while and there's certainly new patients that have come along, I thought it'd be useful to discuss this topic again, and that's specifically which meningiomas should not be treated. So as many of you know, meningiomas oftentimes are treated when we think they're symptomatic or on the verge of becoming symptomatic, but there are a few cases where meningiomas should not be treated. And I'd like to kind of cover some of the generalities of these specific cases. So just one slide on backgrounds. Meningiomas represent approximately 15% of brain tumors. So they're the second most common primary tumor of the brain and spine. And by primary tumor, we are talking about a tumor that starts in the brain. The opposite of primary tumor is a secondary tumor, and a secondary tumor is a tumor that comes from outside of the brain to the brain, like a lung cancer, for example. So meningiomas are the second most common primary brain tumor of the brain and spine. They are more common in women than men by about a 3-to-1 ratio in the brain and a 4-to-1 ratio in the spine. And they usually occur kind of in the middle age range and older, possibly related to hormonal changes as we age. Often meningiomas are discovered because they are causing symptoms, and this usually leads to treatment. There are some meningiomas which can be watched and not treated at all, and the purpose of this discussion is to cover those meningiomas. So the first category of meningiomas which could potentially be watched, and I say potentially because every treatment needs to be specific for each patient. It's individualized and personalized, but in general, meningiomas that are incidental findings have in some instances the option of being observed. So a incidental meningioma is a meningioma that's found as a finding for a workup for another problem. So for example, if you have a brain MRI scan done for something else, let's say you were in a car accident and they were worried about an injury from the car accident, and they scanned your head with a scan in the emergency room and they found a meningioma, that would be considered an incidental finding. So in these cases, the suspected problem, you're working up a fracture of the skull for the car accident is the reason why the scan is ordered, but at the same time, incidental meningioma was discovered, and this is a meningioma the patient did not know anything about. In these cases, oftentimes you just address the main problem, in this case, the skull fracture from the car accident, and you have the option of observing the meningioma if it's not a large meningioma or if it's not likely to cause any urgent or acute medical problems. So I'm going to give you an example of this. So this is a case example, a 45-year-old woman presented with a brain hemorrhage. So a brain hemorrhage is when you have a bleed in the brain. It can be a result of a head trauma. It can also be the result of a stroke. In this case, the cause of the bleeding was a thrombosis of the venous sinus. So a blood clot in one of her veins of the brain led to the brain hemorrhage. So she had an MRI scan performed to work up this brain hemorrhage, and as a result, a meningioma was discovered. So in this case, the meningioma was very small. It was 1 centimeter in diameter. It wasn't part of the hemorrhage nor the cause of the hemorrhage. And the patient did not have any symptoms from this, didn't even know it existed. So this would be a good case in which the meningioma could just be observed. So this is kind of a cross section, what we call a coronal vertical slice through the brain. And you can see there is a meningioma, which is this white structure on the inner lining of the skull. So this would be a relatively small meningioma. It's not causing any problems. We do not expect it to cause any problems in the next year or so. So this is a tumor that we could watch. The one thing you can get into trouble if you watch a tumor too long is that tumors, by just the nature of being a tumor, can grow and often are expected to grow over time. So if you choose to watch a tumor, you can't necessarily be surprised if a few years later the tumor appears larger in size. And one of the issues that many patients struggle with is if you wait, waiting sounds like a good option for many patients, but if you wait and the tumor grows, it can make the treatment more difficult. A larger tumor is associated with increasing complications of treatment. So if you watch a small tumor and let it grow over 10 years to a large tumor and then treat it, the treatment risks would be higher than it would have been if you treated the tumor when it was small. A second category of patients where it can make sense to just observe the tumor and not treat, in the case of a meningioma, are elderly patients. And the definition of elderly you can debate and argue, but I would define an elderly patient as perhaps somebody that has a relatively limited estimated survival. So somebody who you may think is elderly but will live another 20 years in my book is not elderly, because an elderly patient we would define as someone with a limited expected lifespan. So let's say 5 years or less. So because meningiomas are thought to grow slowly in an elderly patient, it's very likely that the patient, if they have a 5-year or lower estimated survival, that something else would happen to that patient that would potentially be life-threatening much earlier than the meningioma. So in other words, the meningioma will not be the problem for this particular patient. So again, elderly, we can talk about what we would consider elderly. I don't use a specific age cutoff. I kind of define it as someone that we think has an estimated survival of 5 years or less based upon their other medical conditions. So let's talk about an example. So this is a 95-year-old patient. She underwent a brain MRI scan because she was having symptoms of dementia. And the family wanted to know, was this just something that's kind of age-related, or is there something going on? And so the MRI scan showed an incidental meningioma. Incidental meaning small, not symptomatic. It appeared to be calcified. Calcification is something that when you see it implies that the tumor has been there for a long time, because calcification takes years to develop. Essentially, it's almost as if bone is being laid down within the tumor itself, and the tumor is essentially becoming fossilized, and that doesn't happen in just a few months or even a year or two. This happens over many years. So when you see calcium on an MRI scan, that tells you the tumor has been there for quite a while. So I just put this slide in here. You can see the patient on the left is a younger patient, and if we found a meningioma in that patient who maybe has a 50-year or a 60-year estimated survival, we would probably recommend treatment, because in that 50 or 60-year period of time, this patient is likely to develop some problems. Now, the patient on the right is a much older patient, And if you found the same size meningioma in that individual, you might say, well, it's very likely that some other medical condition would impact the patient, and therefore the meningioma would not be the ultimate life-threatening problem for the patient in terms of determining overall survival. Now, just as a side note, this is actually the same person. You can see, look, the shirt looks the same. So this was actually a drug smuggler who disguised himself by wearing a costume that made him look very old. He thought he could get through immigration by pretending to be old, but they caught him, they took off his mask, and the picture on the left is him. So you can tell the shirt looks the same. A third category of patients are patients with significant comorbidities. A comorbidity is another medical condition that can impact the patient. So we know that meningiomas by and large are slow growing, and meningiomas tend to be benign tumors, but it's often not likely to find a meningioma as the only medical problem in a patient. So a patient could have a meningioma, but also have things like cancer, kidney or liver failure, significant heart disease, either congestive heart failures or a series of heart attacks, or significant dementia or brain injury. And in those patients, the meningioma is not going to be the primary main problem that's going to be impacting patient survival or their quality of life. And so in these patients, it makes sense to treat the meningioma as not the primary risk to the patient. And so we would often follow these tumors. Now, conversely, if you have a meningioma that's starting to develop symptoms, like you're getting some headaches or weakness because of the meningioma, and you don't have these other problems, then it's likely that you are going to have a longer period of survival, and therefore it may make sense to treat the tumor. So here's an example of a patient with what we would call a significant medical comorbidity. So it's a 56-year-old male. He was diagnosed with lung cancer six months ago. He has widespread cancer throughout his body, and his oncologist says that he's got an estimated survival of about 6 months based upon where the cancer is at this point. Now, as part of a cancer workup, it's very common for the oncologist to order a MRI scan of the brain because they're looking for cancerous tumors in the brain. And when they ordered this scan on this patient, they found a previously undiagnosed, but non-symptomatic meningioma. So this is clearly a patient where the priority should be in terms of addressing the patient's cancer and not worrying about a meningioma that's not symptomatic. So this is the patient's scan. So the scan on the left shows two tumors in the brain, and these are metastatic tumors. This is what lung cancer looks like when it spreads to the brain. And then down in the same scan, but down lower, we see a meningioma, a small incidental meningioma located along the petrous bone there. So the cancer should be addressed, but the meningioma can just be watched at this point because it's not the main problem for the patient in terms of impacting both survival and quality of life. The fourth category in which it can make sense to observe the meningioma is when the treatment risks outweigh the benefits. So all treatment carries some risk. Sometimes the treatment risks are relatively low. For example, if you choose to do radiation for your meningioma, oftentimes there are no surgical risks with it. But all risks carry some treatment. All treatments carry some risks. You have to balance that with the fact that watching a meningioma and not treating also has risks to it. The meningioma could grow. You could develop a lot more symptoms. So watching a tumor is not risk-free. Many patients kind of equate watching a tumor with being, not involving any risk, and that's not really the case. But there are some meningiomas in which the treatment risks outweigh the benefits. And in this case, your physician or your neurosurgeon will tell you to just not treat the tumor. They'll just watch it because the treatment will carry greater risk than just leaving the tumor alone. There's going to be a lot of physician differences when it comes to the risks and benefits, because what may be risky for one neurosurgeon may not be risky for another neurosurgeon in terms of their expertise. So in this situation, if you're being told to kind of watch a meningioma, especially a meningioma that's already causing symptoms, it may be worth getting another opinion to see if that's really what you should be doing. So here's an example. This is a 68-year-old patient that I saw about 4 years ago. She developed gradual weakness in her arms and legs over the course of several years. She undergoes a spine MRI scan, which shows a meningioma pushing on her spinal cord. We would typically recommend either surgery or radiation for this patient. She's not a candidate for surgery because she has other medical conditions like what I outlined before, either heart failure or liver disease or cancer. So she's not really a good candidate for surgery. And because the tumor is pushing on the spinal cord and you radiate the tumor, there's a chance the tumor could swell and cause worsening of her symptoms. So this is kind of what the tumor looks like. You can see it down here pushing on the spinal cord. And in this particular situation, we recommended the patient have just no treatment, observation. Had she presented earlier when the tumor was smaller, I would have recommended radiation. I would not have recommended surgery because she has those other medical problems that would preclude her from surgery. But if we caught this tumor when it was smaller, it would have been a good candidate for the radiation. And just at this point, the tumor's kind of, you can see it taking up the entire spinal canal. She's really no room for the spinal cord. So this tumor has grown too big at this point to safely radiate. Whereas perhaps 5 years ago, it might have been easier and safer to radiate. But at this point, we recommended just observation based upon her other medical conditions. Another category where we would watch a meningioma are meningiomas that have been stable for a long period of time. So by stable, we mean not changing on MRI scans that we've seen for a number of years. And we do have some patients like this. They had an MRI scan, let's say 10 years ago, as part of a workup for an infection or something like that. And an incidental meningioma was found. And over the course of, let's say, the 10 years, MRI scans are obtained every 1 to 2 years. And now we've seen a situation where we have 4 or 5 MRI scans over the last 10 years, and the tumor looks exactly the same. So what this tells us is that this meningioma has been stable for a long period of time and therefore has a higher than average chance of continuing to be stable. We look for calcium again. If we see calcium in the meningioma, that's a clue that it's been there for a long time. Now, having said this, the caveat is that just because it's been stable for a long period of time doesn't mean it can't grow. And we have seen patients where meningiomas have been stable for a long time and then suddenly start growing, including some patients where they grow rapidly. Now, why can this happen? This can happen because meningiomas can upgrade over time, meaning they can go from being a benign tumor to a more aggressive class of meningiomas on their own, even without any intervention. So if you observe a meningioma and it's been stable and then more recently starts to show significant growth, I would personally be concerned that the meningioma has moved from a straightforward benign meningioma to one that is now more aggressive. And there are a few meningiomas that are considered malignant. These are called grade 3 meningiomas, and a benign meningioma can upgrade to a malignant meningioma if you wait long enough. It's not common, but it can happen. So again, that's another potential risk of observing a meningioma, is that you could watch it just progress in front of you from a benign tumor that was treatable to a more malignant tumor. So here's an example. This is a tumor that's been stable over 15 years. So this is a 56-year-old woman. She presented to my clinic for the first time to be evaluated for her meningioma. But she has another medical problem. In this case, it's multiple sclerosis. And multiple sclerosis does impact the brain and shows up on brain scans. So she had a brain MRI scan 15 years ago as part of her multiple sclerosis workup when she was 41. And at that point, a meningioma was identified in her frontal lobe, and this has not grown over time. There was also some calcium present in the meningioma. And so when I saw her 15 years later, we obtained a new MRI scan. The tumor was exactly the same size as it was 15 years ago. So this tumor has been stable for a long period of time. And so it may not make sense to treat this tumor because, it's demonstrated 15 years of no change, and the person, in this case, the patient, does not have any symptoms related to the tumor. So it's stable over 15 years and 0 symptoms, and there's evidence of calcium in the meningioma. So this is one where you could argue that it makes sense to follow the tumor. So this is an example of a tumor, what a calcified tumor looks like. We see on this MRI scan, the brain is this gray material here, and you see this darker black oval. That's evidence of a meningioma with calcification in the meningioma. So this is a situation where we would say, it's been there a long time, it's not changing, it's calcified, we can certainly just observe it. So I wanted to make sure we had enough time for questions, so I'm going to stop here and answer questions that any of the attendees have. There have been some that have come in so far, so I'll just start with the ones that I have. Okay, one question came in. It says it had to do with radiation versus why am I saying radiation as opposed to a name such as a cyberknife. So in general, when I give presentations, I think it's important for patients to kind of be exposed to as broad a scope of treatment options as possible. So I tend to use generic names. I use radiation rather than specific names like gamma knife or cyberknife, because some patients have had radiation on different machines than specifically the cyberknife. And so I think there's not one type of radiation that's the best for treating meningiomas. There's a variety of different types of radiation machines. I've been very specific about using the generic term radiation. At Stanford, we specialized in the cyberknife. So if a patient did require radiation, we would typically use the cyberknife if it was focused radiation. In some cases, if the tumors are very large, we would use conventional radiation. So that's a radiation divided out over 6 weeks rather than just a few sessions. And that's called external beam radiation. And in which case, then, that's conventional standard radiation. So another question came in. It says, why are meningiomas more often in women than men? And that's something I mentioned with the preliminaries, the initial slide that came in. And that's a good question. What we do know is meningiomas have estrogen and progesterone receptors on them in many instances. So for example, 1/3 of meningiomas have estrogen receptors and 75% of meningiomas have progesterone receptors. Estrogens and progesterone are female hormones. They're involved with ovulation and the menstrual cycle. And so the thought process is that the hormonal levels and the types of hormones that are present in women are more likely to be conducive to meningiomas developing. We also know that if you have a meningioma that's not treated and you are on birth control pills or hormone replacement therapy, that can lead to more rapid growth of the meningiomas, presumably because the hormones in either the hormone replacement therapy or the birth control pills are potentially likely to stimulate the meningioma to grow. Meningiomas don't only occur in humans, they occur in dogs and cats and other mammals. And in those species, we also see a predominance in the female of the species. So the next question that came in was, does calcium make it harder to take out tumor material? Yes, it can, because most meningiomas are soft. And when you remove them surgically, you're essentially removing soft tissue, tissue that you can cut out, or tissue that we have other pieces of equipment. One's a sonicator. Essentially, it emulsifies and sonicates the tumor and then allows you to suck out the sonicated tumor. You can do that if the tumor is soft. Now, if the tumor is calcified, you are not able to use a lot of the standard pieces of equipment that we typically use for softer meningiomas. So a calcified meningioma, you can't use a micro scissors or anything to cut, because you're hitting bone. That emulsifier sonicator that I talked about, it's called the CUSA, the cavitron ultrasonic aspirator, doesn't work on calcified meningiomas. So when a meningioma is calcified, it can make it a lot more difficult to take out. So if you see a calcified meningioma that's small and hasn't changed, that would make an argument toward leaving it, because resection can be more challenging. It can be difficult if you have a situation where you have a meningioma that's symptomatic. It's either large or compressing the brain and causing symptoms, and it's calcified, because at that point you have to intervene because the patient is having symptoms, but the calcification means that it's going to be much more laborious to take out the tumor, and you're going to have a much more restricted set of equipment that you could potentially use in that situation. Okay. Another question came in. It says, any idea what causes meningiomas and whether or not they are genetic? So that's a good question. So the answer to that question is yes, we have some idea what causes them. And yes, in some cases they are genetic, and I'll go into the issues here. So with meningiomas, let's answer the second question first. The question is whether they're genetic or not. Most meningiomas are what we call sporadic tumors, meaning that a patient has just one meningioma, that's all they have. They don't have any other family members with meningiomas, so it's just random luck of the draw that they got a meningioma. So that would be considered a sporadic meningioma, and that's probably most of the meningiomas. I would say 90% of meningiomas are sporadic. There are other tumors there, other types of meningioma patients that seem to have meningiomas as part of a genetic syndrome. So if you, let me give you some examples. Neurofibromatosis type 2 is a genetic disorder. It's neurofibroma tumors are present, but those patients often develop other meningiomas in the brain and the spine. So that's an example of an inherited genetic disorder that will predispose a patient to develop meningiomas. That's a common situation there. There are other genetic disorders that patients develop multiple types of tumors throughout their body. They're abbreviated to MEN, multiple endocrine neoplastic syndromes, and you can get meningiomas as part of those. You have some patients that they don't seem to have a genetic syndrome, but they have 3 or 4 meningiomas that are present in the brain, and it does make you wonder, how did they get 3 to 4 tumors? Makes you wonder if there is some sort of genetic predisposition in those patients. I have had families where multiple family members, like for example, a brother and sister both had meningiomas. Also kind of makes you wonder if there's a some sort of genetic relationship. The bottom line is that we don't know all the genes that are involved in causing meningiomas. So it's difficult to be able to test a patient or map out their genes to determine whether or not they are at risk for developing meningiomas. That may be something that will come in the future as we understand more about meningiomas, but right now we don't understand all the different genes that are potentially related in terms of meningioma development. And because we don't understand that, it's hard to know which patients truly have genetically induced meningiomas other than the NF type or syndromes that we're well aware of. And so that leads us to kind of, by just process of elimination, categorize most patients into the category of having a sporadic meningioma, which is a random luck of the draw meningioma. The next question is, what are some new treatment options in the pipeline that would be available in the future? So the challenge with meningiomas is because they are benign and slow growing and typically respond very well to either radiation or surgery, it's not a disease that we struggle with in terms of having treatment options. Meaning that if you're diagnosed with a meningioma, it's not something that's going to immediately impact your quality of life or your survival. And so because of that, there has not been as much of the effort put into research for meningiomas that has been put into things like cancer, where we know if someone's diagnosed with breast cancer, it's going to be a huge impact on their quality of life. If someone's diagnosed with a malignant brain tumor, like a glioblastoma tumor, glioma tumors, the cancerous type of brain tumors, there's a lot more research going into that, because the thought process is that if you can develop improved strategies to manage those type of aggressive tumors, you're going to substantially increase the quality, both survival and quality of life for those patients. With meningiomas, they're not cancerous tumors typically. They tend to be slow growing. There's been not the level of federal research funding allocated toward looking at new trials for meningiomas, because there are good options to treat them at this point. Most of the research money goes into looking at options, looking at treatments of disorders and diseases where we do not have good treatment options for. And because we have good treatment options by and large for meningiomas, there's really not been the level of funding support for that we see in other tumors. Okay. Other questions that people have? I think, did I cover all that? I think there's maybe one, there might be one more question that okay. Yeah, there's a couple more questions here. Okay. From the chat, I'm looking at the chat list now, because some of the questions ended up there. Is there a concern for the frequency of MRI scans for monitoring meningiomas? So this is a very good question, because MRI scans were not developed and used heavily for medical work due to until the mid 1980s. So, before let's say 1985, we really didn't have MRIs available for medical use. The experience with MRIs has only been 30 years, which in the grand scheme of things is not that long a period of time. Now, we do know, obviously, compared to CT scans, MRI scans do not involve any radiation. So CT scans, chest x-rays, mammograms, even walking around outside in the sun, those all involve radiation. MRI scans do not involve any radiation. So getting an MRI scan doesn't expose you to any of the risks of radiation. Now, with an MRI scan, oftentimes when you're looking for meningiomas, the patient will receive some contrast. Contrast is given typically intravenously, and the contrast is gadolinium. Gadolinium is an element on the periodic table. So for those of you that can remember back to chemistry class in high school with a periodic table, gadolinium is one of those elements there. So it's like copper and zinc. It's something that is an element that is tagged to label the tumor. So it makes a tumor light up on the MRI scan. So in order to get the contrast, you're essentially are getting a flush of this gadolinium metal into your body. And there has been some question on whether or not this gadolinium sticks around in your body long term. If we flushed your body with copper every year, you know, is a copper going to stick around in your organ, your tissues? And that's the same concern that's kind of been brought up with the gadolinium. So the general thought process of mine is this. It's that if we're dealing with a situation where, you know, the need to know is more important than the risk of the gadolinium, which is frankly probably extremely low, then we go ahead and give the gadolinium. So if we're newly diagnosing you for a meningioma, or you have a history of cancer where, you know, we don't want to miss the cancer, then of course we give you the gadolinium. The question arises if we've been following you with a meningioma with MRI scans for a number of years and everything looks stable and we can see the tumor without the contrast, without the gadolinium contrast. In that situation, I will often switch patients over to a non-contrast MRI scan. You know, remember, MRIs are not radiation, so there's no risk there of radiation. And if you go with a non-contrast MRI scan, then you won't have a situation of being exposed to the contrast. Keep in mind that you do lose a little bit without getting the contrast. The tumor will not light up as a clear, obvious white spot. You'll have to, you know, you have to be more careful when you read the MRI scans to locate the tumor. It can be somewhat difficult to measure small changes in size of the meningioma without contrast, but any larger changes would be notable. And that's why I think it's reasonable in a patient where we already have established that you have a meningioma to consider non-contrast MRI scans going forward. Okay. Another question came in was, how is a partially calcified tumor removed? That's a good question. So we talked about how calcium can make resection of a tumor more difficult. If the calcium is located in the center of the tumor and the edges are still soft, you can remove the tumor fairly easily, similar to a soft tumor. The challenge in removing a calcified tumor is when the base of the tumor, the portion of the tumor that connects the tumor to the skull, if that's calcified, then it can make it more challenging to remove the tumor. The reason for this is that essentially the tumor is like think of it as a barnacle on the side of a boat for the meningioma. As long as you can scrape the barnacle off the boat, you can get the meningioma out. So as long as where the barnacle is attached to the boat, as long as there's some soft material, you can come across and cut through that material to remove the meningioma. The problem arises when the calcium involves right where the meningioma attaches to the skull. And there is no soft base or neck of the meningioma, and that can be much more difficult to remove. In those cases, you have to use tools that actually are able to break down the calcium, or actually take a drill and drill through the bone like you would for you know, like a skull. So it can be more challenging to remove these calcified meningiomas for that reason. But it doesn't mean you cannot remove them. You certainly can remove them. Your choice of equipment is going to be different. Let's a couple more questions came in. So somebody wrote in, what can we do to police our heads other than annual MRI scans? So are there any dietary changes that should be made? Should we stop drinking alcohol? Should we do voodoo? Should we jump on one foot? So the answer is, yeah, all of those would help. No, actually, just kidding. Here's the trick with meningiomas is that if the meningioma is causing a symptom, like you have a meningioma that's pushing on part of your brain, it's causing you to have arm or leg weakness. Certainly, if your symptoms worsen, you don't necessarily need a new MRI scan to tell you that things are not as good as before. Sometimes your symptoms can worsen even without a change in the size of the meningioma. not because the meningioma is any larger, but perhaps because the meningioma has been pushing on the brain for a longer period of time. So a meningioma pushing on the brain for 10 years is more likely to cause problems than a meningioma that's the exact same size, that's been pushing on the same area of the brain for just 1 year. So one thing you can do is keep an eye on your symptoms. I think sometimes some patients are very highly vigilant on their symptoms. Other time patients are almost somewhat reluctant to say symptoms are worsening because, especially if they've been watching the meningioma and you tell your physician that your symptoms are worsening, they're going to say, well, now we need to get this treated. And if you're a patient who's adverse to choosing treatment, you kind of may downplay your symptoms because you don't want to, end up with treatment, even if that may be in your best interest. So, just keep an eye on the symptoms. Let your doctors know if there's any new symptoms. They can help guide you. We can always order MRI scans if we're concerned about a significant change, but certainly that's something you can watch. Now, in terms of the other comments like dietary changes, alcohol use, so I'm not aware of any real issue with alcohol per se. I think, not to say that you can go, you should do anything other than moderation when it comes to alcohol, but I'm not aware that alcohol is going to make a meningioma grow faster or change anything like that. In terms of dietary changes, it's not really a dietary change, but I would say some of the use of anabolic steroids for performance enhancement, I think can, in some instances, particularly if the hormones are related to growth hormones, increase the chance that the meningioma would grow. So if you're one of these athletes that's taking performance enhancing agents, that could potentially be a concern if you have a meningioma. So another question came in about the presentation. The presentation is recorded. It'll be on my YouTube channel. So if you go to YouTube and look under my name, you'll see not only this recording, but my other recordings that I've talked to you about different meningioma topics. And I put new recordings on there from time to time. So if you check there periodically, you might see something new. Certainly any of the webinars that I've been doing for meningiomas, those go straight from the presentation tonight to my YouTube channel. Okay. Any other questions that have, I think I've covered all the questions. Oh no, there's one more question. Can a meningioma be caused by an earlier head injury? So this question gets asked quite frequently, and the answer to that is I don't have any evidence. I'm not aware that a head injury can cause a meningioma. I don't think there's data out there for this. In general, there's not any type of tumor that I'm aware of that is caused by head injury. Certainly we know head injury can cause things like a head injury can predispose you for a brain hemorrhage. A head injury can give you concussion-like symptoms, concentration problems, dizziness, headaches. A head injury can result in, loss of cognition, things like that. But head injuries typically do not cause tumors, and I think it's an oversimplification to try to link the two together. Usually it means that there's something else going on. If you had a head injury and you got a tumor, those I would work up as independent problems as opposed to trying to put them together. Okay, and I think I got through the questions. So any other questions? I'm happy to answer. I'll stick on for another few minutes to see if other questions come in. But otherwise, as I said, the recording will be on the YouTube channel for anybody to access later. or if you want to re-review them. And we record both the presentation plus the question and answer session. So you'll be able to listen to the Q&A session again as well. Okay, thank you everybody for your time. Actually, another question can't come in. The question about gadolinium toxicity after numerous MRI scans. So yeah, that's that question that gets back to the frequency of the MRI scans. So first of all, gadolinium toxicity is likely to be extremely rare. It's something that we know it's a theoretical risk, and so the issue with the gadolinium toxicity is basically it's unclear. We don't know what the long-term effects of gadolinium are. It's been used for almost 40 years without really any clear-cut data out there. So, and we're talking about millions and millions of MRI scans that have been done. So I think if there is some toxicity, it's extremely, extremely low. And in generally I say, if the need to obtain the information, like the need to make sure you don't have a cancer, that is much more important than the issue with the gadolinium. And you should get the gadolinium to make the medical determination. Now, if you've had a number of scans and we're watching a meningioma and the meningioma hasn't changed in size over 5 or 10 years, then yes, certainly it can make sense to switch to a non-contrast MRI scan. But in general, I think there's an over concern of the gadolinium issue. And I think that in general, gadolinium is safe, especially when you're working up brain tumors. Let's see, there's okay. There are more questions. So somebody asked if I had more slides. No, that was my talk. So, first half of the talk was the slides and the second half of the talk is the Q&A. And then another question came in is, how often should gadolinium be used? Is yearly okay? Again, it depends upon where we are at in the stage of the game. If you've had a newly diagnosed meningioma, like it's your first MRI scan, yes, you should have gadolinium, because we need to understand what's going on with the meningioma, what size it is, where it's attached, things like that. If your meningioma is growing, then you should have gadolinium. If your meningioma is causing a rapid change in symptoms, like 6 months ago, you're great, 3 months ago, your arm was slightly weak, now your arm is densely weak, yes, you should have gadolinium. Now, if we're dealing with a situation where we have a meningioma, we've been watching it for a number of years, it's been stable, sure, non-contrast is okay. If you're in a situation where the patient has, in some cases, you can't give gadolinium because of the renal function and things like that. So if there's a medical contraindication, you don't give gadolinium. But keep in mind that gadolinium, you do lose potentially some information by not giving the gadolinium. So, going with a non-contrast scan, you could end up in a situation where your physician may not have 100% of the information that he would have had with the gadolinium. So by going with non-contrast, you're going to give up some information. The question is, are you at a situation in your following of your meningioma or your treatment of your meningioma that makes sense? So in some cases, in my patients that have cancer, like lung cancer to the brain or melanoma to the brain, I'm getting gadolinium scans, 4 times a year. And we think that's safe because it's more important to know that the cancer is controlled, or do we need to treat it? So, this issue of the gadolinium, it's going to be highly personalized depending upon your circumstance. Another question came, so somebody wrote in and says, I have a question about gadolinium for long-term monitoring of my meningioma. I had 13 MRI scans, and I'm wondering about the gadolinium. So in this situation, if you've had 13 MRI scans and over that period of time, there's been very little growth or no growth in your meningioma, you can certainly, I certainly think it's reasonable at that point to use non-contrast MRI scans and switch it away from gadolinium. But again, if you're telling me that the 12th and 13th MRI scan each have shown growth in the tumor and my symptoms are worsening, then I would say you should stick with the gadolinium. So it again, depends where you are in that and what your clinical condition is and what the last, particularly the last few most recent MRI scans, what they've shown. Okay, I think I got through all the questions. Let's see. Okay, one more question came in. The last question I'll answer before we go is, should renal blood tests be done before contrast MRI scans? So this is a policy that varies from hospital to hospital. Generally, we know as patients get older, their renal function, their kidney function can not be as good, and this gadolinium is excreted or secreted from the body in the urine. So we rely on healthy kidneys to flush the gadolinium out of your body. And generally at Stanford, if you're above 60 years of age, we test renal function before every MRI scan before we give contrast. Other hospitals, we have different age cutoffs. Some hospitals don't necessarily use age; they just go by your medical criteria. Do you have any kidney disorders? Do you have kidney cancer? Have you had one kidney removed? That type of stuff to determine whether or not you get tested. And other hospitals use age cutoff. Stanford uses both. So if you're above 60 years of age, you get a test. If you're younger than 60 years of age, but you have one of those other medical conditions that I discussed, one kidney, prior kidney disorder, kidney injury, kidney cancer, then you would get a test even if you were under 60 years of age. Okay, thank you everybody for attending this webinar. Again, we will post the recording and the Q&A onto the my YouTube channel, so you can watch it again at your leisure. The next support group meeting for the meningioma support group will be Wednesday, December 2nd. So it'll be the first, it's typically the first Wednesday of every third month. So 3 months from now will be December, and the second is the first Wednesday of that month. So that's when the next meeting will occur. Okay, thank you everybody. Have a great evening, okay? Take care. Bye-bye.